currently, patients with FLT3 mutant relapsed and refractory acute myeloid leukemia are eligible in the United States, at least, for treatment with gilteritinib, a newer generation potent FLT3 inhibitor as monotherapy. However, despite these improvement and the availability of a targeted therapy for these individuals, overall, the outcomes of the phase 3 ADMIRAL trial leave much to be desired. For instance, we know that a number of patients who had received prior tyrosine kinase inhibition therapy on that trial did well, but potentially not as well as patients who did not have prior TKI therapy. In addition, we remain concerned about the overall survival of patients treated with gilteritinib. Looking forward, how are we going to cure a FLT3 mutant relapsed refractory AML? We're going to need to be looking at combinatorial therapies. Studies till now have identified several resistance mechanisms for patients failing gilteritinib. These include development of RAS activating mutations, which promote resistance, identification of FLT3 ITD gatekeeper mutations, which constitute a known resistance mechanism, as well as the development in a significant proportion of patients of FLT3 wild type disease. For this reason, the field really is looking towards combining agents, for example, gilteritinib in combination with Venetoclax, to improve overall response rates. A phase 1b study of the combination of gilteritinib and Venetoclax yielded very high overall response rates of 85%, even in individuals who had experienced prior TKI therapy. We're also looking at moving FLT3 novel tyrosine kinase inhibitors into the upfront setting and incorporation of newer generation FLT3 inhibitors in that upfront space, which could thereby reduce the number of patients who have relapse disease. So combinations. Looking forward to having more and more effective combinatory regimens moving forward.